morning. My name is Hanna Danecka. I'm a geriatrician and I work in the Department of Internal Medicine, Rheumatology and Geriatric in Medical University of Gdańsk. And today I'm going to talk about an initiative which we have been developing since almost 2 years in Gdańsk. It is a Center of Geriatric Care, which is an interdisciplinary home-based model for elderly patients. In the beginning, I would like just give you some picture of geriatric care in Poland. And some demographic situation as well. So Poland, from the one point of view, it's maybe still quite young society, but on the other hand, we are one of the most dynamically aging countries in the European Union now. So at the end of 2017, in Poland, we had nearly 6 million of elderly people, which is almost 17% of Polish population. And the thing is that geriatric care is very diverse in Poland. So in the southern part of Poland, we have still quite good network of geriatric care. We have geriatric hospital units, also intermediate care, rehabilitation and outpatient clinic. Whereas in northern part of Poland, where Gdańsk is placed, we come from Pomeranian region. We have really very poor geriatric care. Still there is no good financing for as well hospital care and also ambulatory care. So in some way we are pioneers in our part of country. And the other difficulty which we need to overcome in Poland that is the fact that still integrated care is not a standard. So first of all, which also Professor Kursaal mentioned just before, those two systems like healthcare system and also social support, they are divided. They have financial. They are founded from completely different two sources, and also they have different organization and some law regulations. Also, we have really great fragmentation of healthcare system. And also, I would like to mention about some work culture. Yes, because still in Poland we don't have this good tradition of working together, working in a team, discussion, patients, problems. So I think this is also great lessons we have to learn. Keeping in mind those problems, we put in front of us two main goals for Geriatric Center in Gdańsk. So first one, of course, we would like to develop the coordinated model of care for elderly patients, which is, of course, patient-centered. And also, we would like to involve three main actors, yes, like patient and his or her family, and also some other informal carers, but also healthcare providers and as well social workers. But also, we believe that education really needs to play a great role, because still in Poland we have really a low level of geriatric education. So we would like to educate our patients and their families to show them what is aging process about, what are its clinical consequences, that they could understand and also see even very early symptoms of exacerbation of some chronic diseases they suffer from. And also we see a great need for education for a variety of specialists in the healthcare system, like physicians, nurses, physiotherapists, and also social workers as well. The whole project is possible to develop thanks to some funding from European Union. So now we have really good finances to develop this model. In the beginning, we had started with really great discussion and also a lot of meetings, because we are looking for the good model for us, just in the Poland and in the Pomerania region, just take into consideration the resources, human resources, and also some financial organizational resources we had. So of course, as a geriatrician, we started with comprehensive geriatric assessment, but also we had to do some scientific research, looking in the literature, looking how other people, how other professionals, they created, of course, different models of care for elderly patients. And after this quite long process and then long discussions, we found some main assumptions for our model. So we were sure that we would like to implement some comprehensive support for our elderly patients, but definitely at home and in their environment. So we decided to involve in our model some regular home visits and telephone calls. Also, we understood that it's really necessary to build good interdisciplinary team and to take care after regular team meetings, to build good communication and also cooperation with each other, and also just to develop the individual care plan for patients, and also realize that we desperately need very good, I would say, friendly, user-friendly system, IT system, which will be good repository of all significant data of every patient, and also will really great mean for our good communication and inside the team. We also realized that we still have to be open-minded. Yes, that of course we build some model, and in a moment I will show it more clearly. But also we realize that we have to be still open-minded and care inside some willingness for change. Yes, so we still are prepared for that we have to be flexible and maybe change some main assumptions in time of performing the model. And of course, some other conditions which we found very important is stable financing and also good leadership. So we believe that good leader, which is well, gathering together people who are really good team, they have good communication, and also they share responsibilities. It's really something very important. So in our pilot study, we would like to recruit 90 multimorbid elderly. Probably it will start in the end of May, so in a month time, and we will have free health path care. So we have some patients from primary care, also cardiology, from cardiology outpatient, patients with congestive heart failure, and also 30 patients suffering mainly from COPD. So in our pilot study, of course, it will base on some existing healthcare services, but we would like to broaden it just through broadened by some periodic evaluation using some tools of comprehensive geriatric assessment, also regular home visits by specially trained formal caregivers, and also some comprehensive rehabilitation. And here I would like to show you the scheme of our pilot. So this is a primary care pathway. Here on the top we have some inclusion criteria. So we would like to recruit a geriatric patient, which is defined as patients who are over 65, but also they suffer from at least 3 chronic comorbidities, which need also some active treatment. Also, we decided that those patients will be pre-frail using Edmonton Frail Scale, and then of course they will have some comprehensive geriatric assessment, and after meeting of interdisciplinary team will develop some individual plan. I also put here specific tests and scales we use in geriatric comprehensive assessment because in fact this was again great point for discussion. We really were discussing, it was sometimes even tough discussions between us, which exact scale we should use. We really look again back to literature. For example, was discussion which scales we should use for some cognitive impairment, whether it should be mini mental state examination, maybe MOCA test or clock drawing test, the same with Freyty syndrome, because we have variety tests, variety scales available now. So it was also for us I would say even quite difficult decision which specific methods we should use here. On the next slide you can see specialist care pathways. So here we have patients with COPD or heart failure, and the main inclusion criteria was for COPD exacerbation in last 12 months, and for heart failure there were patients with ejection fraction below 40%, and also the history of exacerbation in last 12 months. In the pilot study we would like to continue, the care should be continued with some interventions like rehabilitation, like those former caregiver visit at home, also some specialist consultations, and if it's needed, also some additional diagnostic. Here it's just in one picture, a 1-year outline of our pilot study. So we plan to perform 3 times the comprehensive geriatric assessment, and also evaluate during the study our previous decisions and maybe change them. Also we would like to support the patient not only with some specialistic consultations, medical consultation, but also some psychological support. So what are outcomes we expect? Firstly, we find that it will be really great to build this, some model of integrated care for elderly people, which still is, in my opinion, really terribly needed in Poland and in our region, and also that we will able to build some user-friendly IT system for good communication and collecting data, the patient's data. Also that we will able to learn how to cooperate together and how to have good communication between different specialists, and also we would like to raise awareness of our policymakers and also local authorities that we really need to radically change the model of care for elderly people. Of course, basing of the resources we have, because during preparation of this model we realized that we have really some resources, yes, but the main thing is just how to coordinate this, and maybe it's not even the problem of great financing, but rather just to the willingness for changing the way of thinking about the care for elderly, and looking for possibilities of coordination. And of course we have also some medical outcomes we would like to measure and evaluate, like reduction of hospitalization, visits in emergency units, also diminishing the risk of institutionalization, and of course cost reduction. Thank you.
Thank you very much, Hanna. Again, you've done very well.
Shall I sit or?
Well, actually, you've done very well, and you're well within your time too. So do you want to take any questions on that? I actually found that very interesting. I also found it very ambitious as well, in terms of wishing to make rational changes to the integrated system that you have as well. I'd like to, any questions from the audience? There's an awful lot in there, and an awful lot for me reflects what's happening in the UK as well, about trying to get health, social care and housing together, to work closely together. Any questions at all? Could I just jump in then, just ask you, in terms of radically changing the model, or in order a more effective integration of all the services, where do you think you'll get the quickest wins from your project to influence that? You know, looked at the different pathways that you...
I can't hear you properly, so I can come closer.
I looked at the different pathways that you drew up there, and looking at your ambition to radically change and improve the integration of the different services. Where do you think the quickest wins will come from? What agencies or what groups of people?
Those caregivers?
care, or the health providers?
With health providers, we have some, because in Medical University of Gdańsk is quite big institution. Also, we work together with Medical University Centre in Gdańsk, so we have really many specialists, and we build the team for taking care of our patient, and also we just recruited caregivers. It was very helpful in Medical University Gdańsk to do it, because our colleagues, they developed some years ago, and they continuing with some model of care for COPD patients. So they really shared with us many experiences, and they also help us to recruit caregivers. So it was much easier basing on their experiences and some network and contacts.
Now, I was just wondering, in terms of your pathways, you have your nurses and your other clinicians involved, and looking at changing their methods of working to improve. I mean, in what groups there might you see your quickest wins?
I think that all groups, I think, also all nurses and physicians, because I think there's also great value of this project, that we learn to listen to each other and to find together some solutions. So I think it's really great value of this project.
So we would say it'll be iterative. Thank you very much. Any other final question? Yeah, super.
Michael Mas from Barcelona. I have a question related to the use of comprehensive geriatric assessment by primary care teams. In your experience, do they use these tools in their daily practice? And if not, what was the impact of the interaction between primary care teams and geriatric teams in the care of other patients? And the last question, did you focus in pre-frail patients? What was the reason why you decided to focus on this population, and why you don't focus on patients with more complex conditions as multimorbid patients? Thank you very much.
Well, maybe I will start with the last question. We definitely focus on multimorbid patients, but we decided to, because we are interested in frailty in general, and but because we planned rehabilitation also, and will be need to come to some facilities, so we thought that maybe frailty patients will be unfortunately not able to come, but I think this is the first, hopefully, the first stage. So if we will get more experience, maybe we will be able also to manage with more in some way difficult patients, more demanding patients. Yes? So because we are starting, because it's some really novelty for us, so that's why we believe that maybe pre-frail patient will be complex enough, but still enough easy to manage. And the previous question, in fact, in Poland, not many in primary care specialists, they use comprehensive geriatric assessment. So in our model, we decided to do it in the team, but we as a geriatrician will be the physicians involved in. Yes, so primary care doctors, they will receive some final result from comprehensive geriatric assessment, and then we will discuss together about the care plan for patient. But we hope that through educational the educational part of this project, we will be able also to encourage primary care physicians to be more interested, and also find, of course, time, because it's also time consuming, but hopefully working together we are able to create some models to implement it in primary care in Poland as well.
Thank you very much. That's a really good question. Thank you. And I agree, if you're actually managing something very complex, such as integration, keep it as simple as possible if you can.